with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. I'm here this evening with my co-host Jim York, and we're here interviewing Dr. Raymond Phillips. Dr. Raymond Phillips is a practicing gastroenterologist with the Gastroenterology Group of Naples, and we have had you on the show before, and we're welcoming you back. And we're going to be talking about colitis and Crohn's disease, or I should say ulcerative colitis and Crohn's disease.
Right.
Before we go into that, Dr. Phillips, why don't you just give us a little background about yourself? And
Oh, sure, absolutely, Jim. I'm a gastroenterologist. I'm a board-certified gastroenterologist, and that represents a culmination of a lot of different training. I went to college at Princeton. I worked my way through college on an ROTC scholarship, and after college, I went to medical school at Washington University in St. Louis. After I graduated from medical school, I did my internal medicine training at Jefferson Hospital in Philadelphia, and then I was chief resident for a fourth year. Now, at that point, I went on active duty in the Army, and I was assigned as an internist to Fort Leonard Wood, Missouri. And I was at Fort Leonard Wood for 2 years. And then I was selected for training in gastroenterology and did my training at Walter Reed Army Medical Center for 2 years. And after I completed my training in gastroenterology, then I was selected to be on the staff at Walter Reed, as well as the Uniforms for Health Sciences, and I was there for 2 additional years. And then I came down here to Naples in the early 90s, and since then I've been practicing with Dr. Susan Lebersky, Dr. Neil Randall, Michael Marks, as well as Dr. Ahmed Khatib. And so our main office is in Naples itself on Goodlet Road, but we also have satellite offices in Bonita as well as in Marco Island.
okay, well, let's talk about Crohn's disease.
Well, yeah, and the reason I brought up this topic about ulcerative colitis and Crohn's disease is that there's a number of different gastrointestinal ailments out there in the community. And increasingly over the years, there has been a blurring as far as the nature of these different types of conditions. And many things now are referred under the general category of colitis. That is to say, including many different conditions. And the reason why it's becoming increasingly important to really be clear about these medical conditions is we have very effective therapy now for ulcerative colitis and Crohn's disease. And so it doesn't help to use vague terms for an individual, and not because they're not well served by vague terms. They need to have a very precise diagnosis because we have very precise and effective therapy for these conditions.
Back in school, we learned about colitis, ulcerative colitis, Crohn's disease, and these were very specific entities. And yet, and what I was saying earlier before we went on air is that it seems that the term colitis is thrown around just loosely, not only by patients but physicians, to describe something that really isn't the colitis that we're talking about.
Yeah, and precisely, because about a third of the United States will have a condition called irritable bowel syndrome. And with irritable bowel syndrome, you can have bloating and cramping and urgent bowel movements. And 50 years ago or 70 years ago, it was referred to as quote-unquote colitis. As we understood the nature of irritable bowel syndrome, it was clear there was no inflammation, no significant inflammation that was part of that condition. But nonetheless, that type of term continues to be used and referred to. And by using sort of imprecise terms like that to refer to a gastrointestinal upset, it makes it unclear to an individual what what their condition is. Now, these very particular diagnoses of ulcerative colitis and Crohn's disease have been very well defined. Ulcerative colitis is an inflammation of the colon itself. Crohn's disease is an inflammation that can involve the colon, but also involves the entire can involve the entire gastrointestinal system. And so Crohn's disease can include much more of the GI tract and have a greater variety of symptoms as opposed to ulcerative colitis. But both of these conditions are provoked as a result of an altered immune response of an individual to some type of stimulation. And what we believe is there's some presentation of certain bacteria within the gastrointestinal system that in a predisposed person triggers an immune response which is excessive and inappropriate and sustained that leads to an activation of the immune system. And in response to that activation of the immune system directs its resources to attack areas of the GI tract, ulcerative colitis, the colon, Crohn's disease, depending multiple potential areas within the gastrointestinal system. But the effect is inflammation, and that inflammation can lead to very particular symptoms. Usually, with ulcerative colitis, you'll have symptoms as far as more urgent movements, frequent movements, in a more severe phase, bloody bowel movements and so forth, which gets people's attention. Crohn's disease will have some of those same type of symptoms, but may have more prominent cramping or pain or bloating as part of it. And weight loss can be a greater component of Crohn's disease. But and these conditions are best diagnosed by a gastroenterologist, and it's those particular type of symptoms, persistent, frequent movements, bleeding, irregularity, the sensation of urgency where you got to get to the bathroom real quick. Those are the kind of things that really gets an individual's attention. But when they go on week after week, that's really an indication that you need to see a physician to really sort this out further. And it's important, as I was saying before the show began, it is important to be able to know exactly what you have, because the therapy is much, much more effective. And we're learning that if we can implement therapy, effective therapy in a timely way, we can intervene before we get major complications associated with each of these conditions. For example, so I'll pause there for a moment here.
Well, the term itis means inflammation. It's a generic term. What is being attacked? What part of the colon or small intestine is being attacked by your own antibodies?
Well, and what I explain to folks is your immune system, which we all have most people seem to have a pretty good understanding that we all have an immune systems, and when it's functioning normally, it helps identify infections and defeat them. And usually the kind of infections we encounter in the day-to-day living are upper respiratory infections, colds, flu, and so forth. But there are all a variety type of infections that we typically consider in terms of skin infections and other things. But the part that a lot of people don't realize, 80 to 90% of your immune system is directed toward your gastrointestinal system. That's where the overwhelming exposure to bacteria occurs, is through your gastrointestinal system. So over the years, and when I say over the years, over the millions of years, our immune system has developed to direct most of its effort toward the intestinal system. And it has developed an extremely effective system to maintain and contain bacteria, principally within the colon, and to create an environment that's harmonious, where those bacteria are contained, but nonetheless can provide, as we discussed in previous shows, beneficial effects to the host, that is to say, you and I. But on occasion, that interaction between the bacteria and the immune system becomes altered. And in that circumstance where there's an alteration and an inappropriate response of your immune system, the immune system directs itself to attack that area where it perceives as a problem. And again, in ulcerative colitis, the issue is within the colon itself. You know, just for those of you to review, when I say colon, we're talking about large intestine, the small, and you have the stomach, which leads to the small intestine. The small intestine is about 18, 20 feet long, and then that flows into the large intestine, which is in the range of 4 to 5 feet long, a little bit longer for women. And and throughout your entire gastrointestinal system, you know, you have a very, very active and constant surveillance by the immune system, but it's principally located within the colon and then the lower portion of the small intestine. And so when there's an alteration in ulcerative colitis, you know, the inflammation's within the colon. And in Crohn's disease, though, it can occur anywhere throughout the gastrointestinal system, but also frequently the colon and the small intestine.
Are people that are like chemo or people that have had like transplants more susceptible to this, or not because of their immune system being affected?
And those are good questions. And in that context, when I explain this to individuals, it's not that they're individuals with ulcerative colitis or Crohn's disease don't have a normal immune system. Their immune system's normal. It just, in this particular area, it's a misdirected effort. And so it's not as a consequence of a diminished immune system as might occur in the setting of with someone receiving chemotherapy, or if they're receiving immune suppressive therapy for a transplantation of some sort. Those individuals are not at any higher risk of developing ulcerative colitis or Crohn's disease. Indeed, some of the therapies that are used for that are sometimes used for ulcerative colitis or Crohn's disease, because you're actually calming down the immune system. But what we've learned now as far as newer therapy is that we've invested about 25 years of very, very detailed studies on the immune system as it relates to colitis. And now we have a very clear idea how that immune system is activated and how the inflammation is initiated. And now with the scientific understanding of that, very, very specific medications have been developed to selectively interfere with parts of the immune system so that this inflammation can be cut short and treated. And that's what I'm referring to as effective therapy. Is there ways of intervening? I was going to say interfering, but intervening in the immune system in a selected fashion to, if you will, calm it down so it doesn't lead to continued inflammation. And now, anytime though you start talking about altering your immune system or talking about that to individuals, you know, it can be kind of scary in terms of the potential concerns about infections. And there are particular infections that you can be more susceptible to with these newer therapies. And when I say newer therapies, we're talking about drugs like Remicade or Humira, and some of the newer ones that are on the horizon. There's a newer drug called Stelara that's available for psoriasis, but it is being investigated for Crohn's disease. It also calms down the immune system. But these drugs work in a very, very selective fashion and make individuals more susceptible to tuberculosis or to fungal infections. And so these are particular conditions we need to screen for and someone whom we're talking about placing on those therapies.
Well, let's take just a short break, and then we'll come back and talk about selectively treating colitis and this autoimmune disease that Dr. Phillips is talking about. We'll be back in just a minute.
If an emergency happened right now, you can have help at the push of a button with Medical Alert.
Remember when I took that fall, Mary?
Oh, yes, that was terrible.
Yes, it was. Help! And I thought, what if you hadn't been there? I ordered my Medical Alert the next day.
I can't describe how safe I feel now with my Medical Alert. You didn't know I was wearing it, did you?
Medical Alert is easy to install, waterproof, and covers you inside your home and out.
It helps me feel safe from fires, break-ins.
And of course, a medical alert. And if you don't have a home phone, don't worry. They have that covered.
There's always help at the push of a button. Don't wait till you need it.
Get Medical Alert for less than $1 a day. There are no long-term contracts. Order now and get your second button free. Call for your free brochure.
For your complete medical alert system with second button free, call 800-604-2791.
Welcome back to Dialogue with a Doctor. We're here this evening with Dr. Raymond Phillips, and we're talking about ulcerative colitis and Crohn's disease. These are both autoimmune diseases of the intestine. And we're going to talk a little bit more about that and also about potential treatments.
Well, yes, and as we've been dwelling on, the theme is that for these conditions now we have effective therapy, very effective therapy. Trials that have been conducted over the last 15 years under the supervision of the Food and Drug Administration. And as a result, we have a very clear understanding about these drugs and how they work and also their risk profile. And it's when we begin to discuss using these medications, you know, we like to discuss the risks so it's transparent with individuals. And many times when these risks are beginning to be discussed, people become frightened of these potential risks and sometimes inflate risks that are very, very remote and sometimes become scared about the prospect of embracing effective therapy, and instead of relying on therapy that's sort of unproven or ineffective or has its own potential risks. So for example, for the last 60 years, the standard therapy for both of these conditions was the use of steroids. And steroids in the 1950s, initially it looked like it was a cure for everything, even including Crohn's disease and ulcerative colitis. But after a short time, within a few months of its being developed, or a year or two, it was pretty clear it wasn't a cure at all and came at great cost the longer and longer you use steroids. And the cost being risk for infections, a risk of bone disease to the extent of osteoporosis, or conditions in terms of susceptibility in terms of mood changes, skin changes, muscle weakness, changes in your psychological condition, so forth. In fact, if you go through it, steroids will affect every system in your body in some fashion if you take it long enough. But for lack of more effective therapy for more severe conditions, that has been what's been used for many, many years for ulcerative colitis and Crohn's disease. As we understood the immune system and developed medications that could calm it down, these very, very specific drugs now like Remicade and Humira have been developed in these last 15 years. And they do interfere with the immune system, as we were talking about a moment ago. But the risk profile is much, much better, if you will, than compared to a drug like steroids. But because we have a very clear understanding about the risk profile for these drugs, when we discuss it, people will often focus in on these potential risks. Say, for example, with Crohn's disease and ulcerative colitis, because it's an activation of the immune system, there is a higher risk of lymphoma even if you receive no therapy at all. If you receive no therapy at all for Crohn's disease, there's a risk of developing lymphoma, say 2 in 10,000 over the course of a year. And that's the immune system's being activated, being stimulated, and as a result that makes you more susceptible to lymphoma. Well, when you use a drug like Remicade or Humira, that risk goes up to 4 in 10,000. So on the face of it, you're doubling the risk. That sounds terrible. Well, like if you take a place like Germain Arena, completely filled up, 10,000 people, 2 seats out of 10,000 might develop a lymphoma if no therapy is initiated. And if you initiate therapy, maybe 4 in 10,000. So yes, it doubles the risk, but the risk is very, very small, very, very remote. And the difficulties provoked by ulcerative colitis and Crohn's disease are very real, very immediate in terms of what the kind of conditions it can provoke, and in terms of an individual's capability of functioning. So I'm not minimizing risk. I'm just saying it's worthwhile to put all risk into perspective when we consider these newer therapies. And to also understand that, some therapies which hold promise, like for example, probiotics or dietary therapy, or those things hold promise, but the promise has been not delivered. And we've not been able to identify dietary interventions or manipulations in probiotics that can be beneficial in ulcerative colitis or Crohn's disease. So it's important to realize that, although these things look promising, they just not have been investigated in any scientific fashion. And when someone who's desperately ill from a more severe version of these conditions, they really deserve our best and most effective therapy from the beginning. And by doing that, we can prevent substantial, complications associated with ulcerative colitis and Crohn's disease, and potentially prevent, difficult or disfiguring surgery. That can be a real problem, particularly since the age groups that are often affected by these conditions are very young individuals, and so young adults at the time when it's very at their peak productivity, and can certainly affect their lives greatly.
I think to that point, I think many patients they don't realize that ulcerative colitis is a serious entity. People can lose their colon, they can lose pieces of their colon, they can have an infection that can kill them if it's not treated correctly.
Well, yeah, and exactly, and when we say ulcerative colitis, or in particular, it can cause such a severe inflammation of the colon that it can cause the colon to be dysfunctional, so that it's just not functional at all. And one response to that, what has been available for years and years, and I should say, in deference to my surgical colleagues, that there has been effective therapy for ulcerative colitis for years. Well, if you remove the colon, you won't have colitis. And so that is an effective approach to ulcerative colitis. And for years and years, though, that often led to an ileostomy, and that was not terribly appealing for many people. To have an ileostomy, of course, is where with removal of the colon, you'd have a collection of the waste material from a bag on the abdominal wall. And that was modified about 25 years ago, such that a new rectum could be constructed out of small intestine. But still, that's a very difficult operation. It's not an easy thing to perform. And it requires a colorectal surgeon of great skill who can do that in a successful fashion. And but the reason I mentioned it is just to emphasize that has been effective therapy for years. And so I don't want to take away anything from our surgical colleagues, but I do. And when I say effective therapy, I meant that in the context of saying now medically effective therapy, that would provide an alternative to surgery. Mm-hmm. So I guess the point I'm leading to is that and I think the themes we're trying to get is clarity as far as the diagnosis. If you have symptoms that are really intractable, that are interfering with your life and ability to sleep, hey, you need to see a physician and probably a gastroenterologist. And then the additional point is, with that clarity as far as diagnosis, implementing effective therapy as soon as possible can lead to a much more rapid resolution and improvement of an individual and get them back to a normal life.
Briefly, how do you make the diagnosis of ulcerative colitis or even Crohn's disease? It's harder to get to the small intestine.
Right.
But how do you do that?
Well, there's a variety of techniques that have been developed, endoscopic techniques. You know, we've talked about colonoscopy on previous shows, where it's a flexible telescope while an individual is sleeping allows us to examine the entire extent of the colon. We have the counterpart to that, upper endoscopes, that allow us to examine the stomach and the small intestine. Newer innovation to allow us to look at the entire extent of the small intestine is this device called a video capsule, a miniature video camera that allows us, when it's swallowed, to traverse the small intestine and to transmit images back to a receiver on your way. So we're able to get an image of the entire small intestine, 75,000 images, but sufficiently detailed that we can really comment or observe whether there's inflammation within the small intestine.
You take a biopsy to prove it?
Well, a biopsy is essential to be able to prove that you have these conditions. And the biopsy is particularly useful because, like all things in life, there can be ambiguity between these two conditions. That is to say, it's not black and it's not all white. There can be a gray area between these two conditions where you can have symptoms and appearance on a scope examination that can be unclear as to whether it represents ulcerative colitis or Crohn's disease. And a biopsy helps make that distinction more effective. Now, fortunately, and even now, interestingly, the therapy for both of these conditions is very similar. And so although you sometimes cannot say definitely whether you have ulcerative colitis or Crohn's disease, fortunately the therapy for both is very, very similar. So therapy has been successful even if you don't have a precise diagnosis.
Has there been any research to try and correct the imbalance, meaning, yes, Remicade and Humira can interfere with immunity, but can you set it back to normalcy?
Well, and that's an area of intense research right now, and it relates, and I'll just say it briefly because we have little time here and so forth. But as I said before, this represents an aberrant response of the immune system to bacteria within the gastrointestinal system. There's a great deal of research looking at, hey, perhaps if we replace the bacteria within the GI tract, perhaps if we provide a stool transplantation and provide a new microbiome, a new bacterial flora that shows proper diversity that will interact more appropriately with the immune system, that may reset the immune system back to normal, which is what you're sort of driving at with that question.
That would be interesting. Replace the whole stool and fix it all. We want to thank you very much for teaching us about all this, and we would like you to come back and teach us about other things. Thanks a lot.
Thanks so much. Thanks, Greg. Thanks, Jim.
Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with the Doctor. We're here this evening with Dr. Raymond Phillips. He is a practicing gastroenterologist here in Naples, Florida. And he's been with us before more than once, and we're welcoming him back. We will be talking about constipation, which sounds like a simple thing, but it's not that simple, and we want to learn more about it from Dr. Phillips.
Dr. Phillips, before we get into it, I know you've been on the show before, but can you give us a little bit of your background?
Oh, sure, I'd be happy to.
Where your offices are located?
Yeah, sure. First, it's important to know what a gastroenterologist is. A gastroenterologist is specifically trained in terms of digestive diseases, gastrointestinal ailments, as well as in the physiology of digestion. We're the only specialty trained in that. But to achieve that, you go to college. I went to Princeton. I went to medical school at Washington University in St. Louis. Did my internal medicine training at Jefferson Hospital in Philadelphia for 3 years. I spent a 4th year as chief resident there. I was selected for that. And then I went through college on an ROTC scholarship and went on active duty after training at Jefferson. And I was assigned to Fort Leonard Wood, Missouri for 2 years as an internist, adult medical doctor. And then I was selected for gastrointestinal training, a gastroenterology fellowship, and was trained at Walter Reed Army Medical Center for 2 years. And then I was on the staff at Walter Reed for 2 years where I did research, and I was assistant chief of the department and as assistant professor of medicine and uniform services for health sciences. And then in the early 1990s, I came down here to Naples to practice when I got out of the Army. And since then, our practice has grown. We have our main office is in Naples and Goodlet Road. And our practice has grown to the extent that Dr. Susan Lebersky came to join us. And then I also practiced with Dr. Neil Randall, Dr. Michael Marks, and Dr. Ahmed Khatib. As I said, our main office is in Naples, but we also have satellite offices in Bonita as well as Marco Island. So yes, we're trying to serve the needs of Collier County and South Lee County as far as the gastrointestinal needs.
Well, let's get into the topic of constipation, which I'm sure everyone has had one time or another, right?
Well, constipation is really a universal experience for everybody at some point in our lives. And typically it's defined as less frequent movements, less frequently than desired, sometimes difficult bowel movements or difficult evacuations. And it's been studied very, very closely for men and women in terms of what's appropriate interval for frequency for women as well as men. Interestingly, most of these studies were done in England, but they're applicable to the United States as well. With Oprah's show about 4 years ago about the description about stool and so forth, what's appropriate. Now that highlighted a particular scale called the Bristol Stool Scale, which gives a description of appearance of stool. But suffice to say, with constipation, it's a universal symptom, and the perception of the need to evacuate or inability to evacuate or less than complete evacuation. But I got to tell you, there's a long history on the issues of constipation in the United States. The United States and constipation are closely related. It dates back to the mid-1800s as the first reports of public perception or discussion of constipation, when this Presbyterian minister named Sylvester Graham first sort of promoted the notion that constipation was as a consequence of a diminished fiber content in the American diet. And so he would go from city to city promoting a high fiber diet, talking about the virtues of fiber. Every city he came to, though, all the butchers sort of would come up and riot and so forth, so he's banned from certain cities like Boston and so forth. An interesting side note about constipation being was he felt like constipation was the basis for sexual promiscuity. So and so he advocated a high fiber diet as a means to address that in American psyche and nature. He was a very influential speaker, and he had, as a result of his speakings, he attracted a number of disciples, if you will. Among them a person by the name of John Kellogg and another individual by the name of Post. And they attended his lectures and they embraced his notion, and each of them set out in their own fashion to develop an appropriate meal for the American family for breakfast. And Post developed, his initial product was called Manna from Heaven, never sold. But then his marketing director renamed it Post Toasties, and it was just a humdinger of success. And then Kellogg, he had a product derived from flakes of corn and so forth. Tasted terrible. Sales were terrible. Brother suggested they added some sugar to it. Sales just escalated, and it went off the roof there, and they had quite a success for years and years. They never spoke to one another, though, because adding sugar to the product made John Kellogg upset, so he never spoke to him again. At any rate, they both settled and became bitter enemies in Battle Creek, Michigan. Unfortunately, Mr. Post, he died early, and his daughter, Emily, went on to become an icon in American society in the early 1900s. So there's been a close connection with the issue of American history and constipation. But it reached great intensity in the late 1800s because it was realized that was the development of the hypodermic needle. And initial studies where stool was extracted from mice, and that stool extract was injected back into the belly of a mouse, the mice would keel over and die within a couple hours. So it was felt that there was toxins within the stool that needed to be evacuated on a regular basis in order to maintain health. Now that was disproven in the early 1900s with the advent of microbiology and so forth. We're dying of overwhelming sepsis from injecting stool into their bloodstream. But nonetheless, the lingering notion of toxins in your stool, needing to be evacuated on a regular basis became embedded in American psyche. And so in the early 1900s, it was routine for American mothers to provide laxatives on a regular basis to their children so they would have regular evacuations. Or enemas, as the case may be, so their children could grow up and be healthy and not be subjected to certain toxins as a result of constipation. And that concept nearly died out until the late 1900s, within the advent of colonic cleansing arose once more, and interestingly was promoted by Princess Diana. But that's another story.
Many of my patients who come in do not know what the word constipation means. Maybe you could define that, because patients will come in and say, well, I'm constipated. And then I'll say, well, when was your last bowel movement? Well, it was 2 hours ago. Yet they're complaining about a sensation. So could you define for us or for our viewers so they know what that is?
And that's really an important question, Greg, because there can be an objective criteria in terms of frequency of movements. That is to say, if you have, and as I said, I alluded to a moment ago, is that for men and women, there have been systematic studies to show what's normal for women. Typically, a movement a day is normal for women, 5 to 7 movements per week. For men, it's 2 to 3 per day, or as few as 3 per week. But that's a numerical definition. You can also have meet the criteria of constipation with the sensation of incomplete evacuation, or the urge to evacuate but not successful evacuation. And so an individual may be evacuating on a regular basis but still have the perception that somehow they're uncomfortable or they need to evacuate. So it can be a little bit imprecise, and it's important when discussing this to really clarify exactly what the symptom that's being and not just assume that it refers to infrequent movements. For example, an individual may have regular evacuations each day, but if the movement is particularly difficult to evacuate or hard, they may be very uncomfortable with that, and as a result, that needs to be addressed. Now, you might say, well, how would you address that? Well, and why does it occur? And there are a number of different factors that can lead to difficulties. Diminished fluid intake, for example, or diminished fiber intake, as we were referring to a moment ago. I should say Sylvester Graham, he developed the graham cracker, which was a great success as well, and his effort and his contribution toward contributing to a higher fiber diet for the American population. But a higher fiber diet and increased fluid intake will help many people, but in some individuals, that will not make a difference, because there are some individuals where they can have an alteration in the normal peristalsis, the normal motility, the normal contractions within the GI tract, such that they don't necessarily have regular or predictable evacuations. And as a result, the longer material resides within the colon, more fluid is extracted from that material, and the stools become harder, more compact, and more difficult to evacuate. So in the last 50 years, the issue of therapy for constipation has been very neglected. Laxatives from years and years ago are still used on a routine basis, milk of magnesia, for example, or different types of stimulant laxatives like Cascara or Senna. Senna now has made a comeback. Formerly it was popular in the form of Senecot, but now it's been included in a number of herbal teas now, and it comes under the name Senna, S-E-N-N-A, and it's promoted as an herbal tea, but it is a stimulant laxative. In an effort to be more systematic and sort of addressing this need in the American public, a number of new laxatives now in the last 10 years now have been researched and shown to be effective and available for use. And they are very, very useful. But before you start turning your attention to laxatives, the basic things are important to do in terms of an adequate fluid intake, an adequate fiber intake. And fluid intake is very individual. It depends on the environment you're in and your body size and your activity and so forth. And for example, in Florida, most people are dehydrated, so it's important to get a greater quantity of fluids than it would be if you're living in a cooler climate. And fiber content is a little bit vague, but generally what is recommended by the FDA now is 5 to 7 servings of fruit and vegetables a day as a way of trying to achieve that. Yes, indeed, you can take fiber supplements in forms of different varieties like Citracel or Metamucil or Fibercon, but it's so much more interesting to eat your food than to take a tablet. And so the preference would be to meet those requirements of fiber intake through eating more fruit and vegetables. But yeah, there's just an occasional individual that despite everything you do, you need to turn your attention toward other interventions. Now, it's important to understand, if someone has constipation and it's a new finding, it really does need to be evaluated by a physician to be clear that it's not something substantial in terms of a developing obstruction or blockage from something more serious like a tumor or cancer. But in general, individuals who have had difficulties with constipation, it's oftentimes been a long-standing experience and not a short-term one. Finally, I shouldn't neglect that many different medications now will affect and promote constipation. And it's a consequence of some of our success with these different medications that we use for different conditions. It can affect the gastrointestinal system and diminish how readily and how rapidly the muscles that line the gastrointestinal system work in terms of regulation. So, for example, there's medications that help reduce the urgency in terms of urinary urgencies that many people will have who have an enlarged prostate, for example. But that same medication also diminishes the gastrointestinal system's ability of the muscles to work efficiently, and that can promote constipation.
Well, we're going to take a short break and come back and talk more about some of the medications for constipation, or at least even other treatments for constipation.
Oh, absolutely. It's an exciting topic.
We'll be right back.
An exploding field, if you will. Okay.
We'll be back in just a moment.
If an emergency happened right now, you can have help at the push of a button with Medical Alert.
Remember when I took that fall, Mary?
Oh, yes, that was terrible.
Yes, it was. Help! And I thought, what if you hadn't been there? I ordered my medical alert the next day.
I can't describe how safe I feel now with my medical alert. You didn't know I was wearing it, did you?
Medical Alert is easy to install, waterproof, and covers you inside your home and out.
It helps me feel safe from fires, break-ins.
And of course, a medical alert. And if you don't have a home phone, don't worry. They have that covered.
There's always help at the push of a button. Don't wait till you need it.
Get Medical Alert for less than $1 a day. There are no long-term contracts. Order now and get your second button free. Call for your free brochure.
For your complete medical alert system with second button free, call 800-604-2791.
Welcome back to our show, Dialogue with the Doctor. We are here this evening with Dr. Raymond Phillips, a practicing gastroenterology specialist from Naples, and I'm here with Jim York. And we've been talking about constipation, which in a way is an interesting subject because not much is known about it, and so we're learning more about it today. But we're going to talk more about medication treatment.
Well, exactly, and I should preface this by saying that it's important if you have a new onset of constipation or change in bowel habits associated with that, be it constipation as we defined earlier as a sensation on evacuating or difficult evacuation, frequent evacuation, yeah, that does deserve medical attention and evaluation. But assuming that, hey, that medical evaluation now has been done and there's no sign of any kind of blockage or narrowing, and an individual has made an effort to increase the fluid content of their diet, the dietary content in terms of fiber by eating the fruit and vegetables and so forth. And then also, as we were saying a moment ago, re-examining the medications that are being used to be confident that they're not provoking constipation. Just as an aside, many pain medications now are all constipating. And, well, they've always been throughout history, but with the availability of these medications and used more broadly in the last 15 years, it's become clear that, pain medications, and I'm talking now in particular ones that are opioid-based, will promote and provoke constipation. But now there are, in the last 10 years now, there have become available a number of different medications that are very effective for treatment of constipation. One of them is it's called Miralax, and it's a medication that comes in a powder form, but it's interesting because it's not a powder like you might think of in terms of a fiber additive. It's actually polyethylene glycol. You know that ethylene glycol that you studied in high school, which is antifreeze basically. But by taking ethylene glycol, antifreeze, and constructing a large molecule made up of thousands of individual molecules, it's extremely safe. You're not going to poison anybody by taking this.
Polymer?
It's a large polymer. That's the formal name for a large molecule that's been comprised of many, many smaller molecules. And the nature of that is that when you add this to fluid, it prevents that fluid from being absorbed into the bloodstream. So when you add this powder to 8 ounces of fluid and drink it, within a day or so, 8 ounces comes out the other end. So it maintains a certain level of fluid within your gastrointestinal system, which it was quite remarkable because your whole gastrointestinal system is designed to absorb fluid, as to extract fluid. And to be able to and to counteract that tendency is quite effective. It's quite remarkable. But by maintaining that fluid in your GI tract, that maintains a certain volume of material within your colon. That in turn distends the colon, stimulates it to contract, and that stimulation to contract is what sort of propels things through your system and allows an evacuation. Now, and this is an area of tremendous research. Other drugs now have become available. Amitiza is another, Linzess is another. These are drugs that stimulate fluid production, fluid release within the gastrointestinal system, and that fluid release then in turn accumulates a certain amount of fluid within the colon and stimulates it in the way I've just described.
Is that prescription only?
These drugs are prescription. Now, Miralax is available over the counter, does not require prescription. These other two drugs that I'm describing to you are prescription items. And so it's important to consult with your physician.
You have to be careful that you don't get dehydrated when you're doing this? Or
Well,
not?
these are drugs that can have that potential side effect in terms of if used excessively, you can cause a loss of fluids that can dehydrate you. And, but as I said a moment ago, it's important, and that's a fundamental issue that needs to be addressed first before turning our attention toward pharmacological therapy with medications to treat this. But the exciting thing about these newer therapies is that they're extremely effective. They're extremely effective, and the risk profile, the side effect profile is very, very good. And other than the cost, which is substantial, they seem to have a great benefit and are very effective in a short-term fashion. Now, none of these drugs have necessarily been looked at on a long-term basis. The only one that has had long-term studies is Miralax, and those studies have gone up to 1 year in duration. And even at that point, it's still effective and appears to be continues to be safe. These other drugs that I've mentioned, though, don't have long-term studies to give you a sort of a confidence that you can use this on an ongoing basis. And of course, none of these drugs have necessarily been well studied in children or pregnancy, so it's a little bit difficult there. Pregnancy, routinely you become constipated, and that's associated with a change in sort of hormonal balance. And children, for a variety of reasons, can sometimes be constipated, given the sort of the regimented nature of children going to school and so forth. You can promote constipation in that context.
So if you were to, getting back just to the beginning of your conversation about patients sometimes talking about ridding the body of toxins and evacuating the colon in order to do that, and that conception came from that original piece of information that you talked to us about.
Correct.
But that since has been proven not really to be correct. Yet this practice is stronger today than it was, to me, even 15 or 20 years ago, or this concept.
Yeah, and it continues to be show up again and again, and different individuals, celebrities, tend to promote this concept, and it really is a false concept. That is to say that there are toxins within the colon that need to be evacuated. Your gastrointestinal system is very effective as far as handling any toxins, evacuating any toxins. Granted, if you're not evacuating on a regular basis and you're constipated, you can get retention of gas and stool that can make you uncomfortable, but there is no release of any toxins into your bloodstream that will affect your overall health. However, some individuals in particular who have agendas with regard to dietary interventions will promote the notion, that somehow certain foods will linger and reside within the gastrointestinal system and colon and lead to
For years.
and
where does that come
these
from?
very vivid images of putrefaction, of rotting flesh inside of your colon, of protein in particular, leading to toxin release is just not accurate at all, and just a false science altogether, but has been used to promote these practices of colon cleansings, of cleanses of various sorts, either through enema or oral preparations, with the notion that somehow you will be healthier as a result of pursuing these interventions.
But we know that when you increase throughput or have diarrhea, you will lose electrolyte, you lose, well, you can tell me what you'd lose, sodium, potassium, chloride. So in theory, you can lose those things. What else is there to lose? That I'm just trying to get at this subject,
Well, this is an important subject because Well, for example, if you go to these different therapies, colon cleansings, certainly you're going to lose money out of your pocket, all right, because they're not giving this stuff away. And when you have individuals that are being receiving either laxatives of various sorts in an unsupervised fashion, you can lose great quantities of fluid, sometimes potassium, and that loss of potassium can sometimes cause a number of other symptoms like cramping, irritability of your heart, and leading to irregular heart rhythms. And that's part of the reason why anorexics who purge will sometimes die as a result of taking various laxatives because of alteration in their potassium level that causes an irritability to the heart. That's how Karen Carpenter died years ago. So it's a circumstance where you can have real consequences and real side effects of pursuing therapy in an effort to pursue good health. And so that's not even talking about the mechanical effects of some of these these enemas, that is to say, administration of fluid into the colon to evacuate the colon. Sometimes that can even lead to damage to the colon or perforation of the colon itself, which can be dangerous and life-threatening. So there are consequences to pursuing therapy like this that's not approved, and as a result, we're encouraging people, particularly now since we have effective therapy, we have a good understanding about the nature of constipation, that you should see a physician and be evaluated and have some, develop a plan of action as far as an ongoing approach to this. It doesn't necessarily involve taking medications. As we talked about, there's much you can do on your own that doesn't require medications. But it does require a thoughtful approach to the extent of, and not being frightened into pursuing expensive therapy that's not going to really benefit you at all and potentially can have a lot of side effects.
So eat real food, but if that doesn't work, see your doctor.
Well, do what your mother told you to do. Eat your fruit and vegetables and drink plenty of fluids. And that's a good start. So that's a great start in terms of being able to have a healthy lifestyle and be more comfortable.
Thank you for
Yeah, we want to thank you again.
You're welcome.
Learned
Thanks.
a lot once again.
Well, thanks.
And we do want you to come back.
Oh, I'd be happy to.
Thank you for being with us.